everyone. I'm going to go through the oral rehab final exam. It opens on Saturday, December 14th, and it closes at midnight on December 17th, so make sure you get it done within that window of time. So, a little overview. The exam will cover materials from chapters 12 through 15, so it'll be pediatrics, and there's going to be a total of 50 questions, and you will have 120 minutes to complete it. And the type of questions include written responses, matching, and multiple choice. There's quite a few written responses, so be prepared for that. So now we'll just get into the content. So for hearing loss statistics, know that 3 per 1,000 infants are born with a severe to profound hearing loss. Additionally, 6 per 1,000 children will incur permanent hearing loss by school age. And for every 1,000 children, 83 have an educationally significant hearing loss. And approximately 40% of hearing impaired children have another disability besides a hearing loss. And sensory neural hearing loss is the most common birth defect in the United States. So you're going to want to know the 15 risk factors for JCIH, which include parental concerns, family history, NICU for less or greater than 5 days, ECMO, ventilation, craniofacial abnormalities, neurodegenerative disorders, head trauma, chemotherapy, meningitis, syndromes, ototoxic medications, loop diuretes, and hyperbilirubinemia. And in utero infection. For in uterine infections, CMV, so it's a viral infection that mom has while pregnant. Infection rate is 0.6 to 3%. And then 15 to 20% of children will have lasting effects. And these include cognitive disabilities, vision issues, sensorineural hearing loss, that's often progressive, and then microcephaly and cerebral palsy and seizures. And 6,000 children are affected annually in the U.S. with this. So for genetics, you're going to want to know the types. So there's autosomal dominant. So that means that one parent passes a dominant allele to children. So it's 50% inheritance rate. And then there's also autosomal recessive. So both of the children's parents carry a gene with the probability of the gene being expressed in the child being 25%. And then X-linked is more rare and refers to the mother XX carrying a recessive allele for a trait on the sex chromosome. It's not expressed in female XX children, but it is passed to males XY children, so 50% chance of passing it to their sons. So for sensorineural hearing loss, genetic causes, there's syndromes, which is a collection of conditions that co-occur as a result of a single cause and constitute a distinct clinical entity. So examples of this with sensorineural hearing loss is Down syndrome, Usher syndrome, and Teeter-Collins. For screening procedures, more than 95% of newborns in the U.S. are screened for hearing loss. And UNHS use ABRs and OAEs, and they are on a pass or refer basis. So the child either passes the test or is referred to an audiologist. And then otoacoustic emission testing. And that's when a specific sound is sent to the ear that stimulates the outer hair cells of the cochlea and emit an echo out of the back of the ear. And then OAEs can be measured in individuals who have normal hearing or a mild hearing loss. Individuals with a moderate hearing loss or greater, such as conductive or sensorineural hearing loss, will not emit that small echo. So there's auditory brainstem response, which is referred to at the top, and their electrodes are placed in the baby's head and behind the ears. And then headphones or insert headphones play a click or tone burst into the ears one at a time. The electrodes pick up neural activity of the auditory nerve and brainstem, elicit the tone, burst, or the click, and the response is recorded. And then the auditory brainstem response is an electrophysical response to an acoustic signal. A normal response will correlate with behavioral thresholds from 5,000 to 4,000 hertz. Okay. And then after screening, so if the baby passes his or her newborn hearing screening and has no risk factors for a hearing loss, they're sent home. If the baby passes their newborn hearing screening, but there is risk factors for hearing loss, he is recommended for a follow-up with an audiologist. And if the baby fails, they're rescreened. And then if the baby fails their rescreen, they are told to follow up with an audiologist for a diagnostic workup. And 20% of newborns who failed their newborn hearing screening don't receive follow-up in a timely manner or at all. So, for mixed hearing loss, just know that it is common for children with hearing loss to have mixed hearing loss, such as chronic otitis media, head or neck or ear malfunctions, ossicular chainmail formation, and perforated tympanic membrane. So, effects of a mild hearing loss: they might have difficulty hearing, especially with a lot of background noise going on. Their speech and language could be delayed, and there's a greater concentration needed to hear, so they're working a lot harder. And then they can also have poor academic performance as a result. They're also more likely to repeat a grade, and they tend to have poor self-esteem. So, effects of unilateral hearing loss. So, children with unilateral hearing loss compared to non-hearing loss children. So, their poor localization compared to normal hearing peers. And then also, they perform worse on speech perception in noise. And then the effects of it affects their language and cognition possibly. And then they tend to perform worse during complex tasks with multiple talkers. And then patterns of looking behaviors differ and suggesting differences in use of visual information. Then when asked to find talkers and repeat what they say, children with unilateral hearing loss may talk longer to find the talker than peers with non-hearing loss. And they may benefit from seeing the talker. So ANSD affects the peripheral auditory system. It's the inability of the auditory nerve to send a clear signal to the brain stem/brain. And it may present as normal hearing sensitivity to profound hearing sensitivity via audiometry. And OAE is normal. And then they have abnormal or absent ABR. And they're likely to have poor speech recognition skills, poorer than we would expect to see by the person's audiogram. Okay. So for the birth to 3 group, they're allowed to have the individualized family service plan. Early intervention services are provided for birth to 3 years of age. There's an emphasis on family involvement in the process. So the IFSP includes children's level of development, family concerns, priorities, and resources, and then outcomes and program monitoring, intervention services and how often they are provided, environment providing early intervention services, and then medical, home, and start date and duration of services, as well as a service coordinator, and plan for transitioning to preschool. So all of those aspects are incorporated in the IFSP. So for the early intervention, the family selects which type of program it wants to do. So there's either the home-based, which is encouraged, and a specialist goes to the child's house, and then there's a center-based, where the child attends therapy at an outside environment, and examples of this are the Spots House in Chippewa Falls. For communication mode choice, there's different options, and the parents and guardians decide what would be best for their family and their child. So there's the oral language, and then ASL, signed English, and cued speech. They also need to think about listening devices, such as hearing aids, cochlear implants, and ALDs. So all families have the choice of which communication mode they want for their child, and then some communication modes may be encouraged more than others for different medical and audiological purposes. For amplification, so early intervening services are a must. Selection and other amplification issues may arise, so you kind of have to work through the entire process. Advanced technologies are beneficial. Also, keep in mind that they are more costly. And behind the ear instruments are preferred for pediatrics. And then children should see a pediatric audiologist with history of fitting infants or children. And then verification and validation of the technology is a must. And a trial with the hearing aids need to be completed before a cochlear implant can be implemented. For speech reading, it's the ability to utilize the visual speech signal to show development and trajectory as it is affected by a child's hearing status. And as children develop better speech and language skills, they also improve in the ability to utilize speech reading skills. So the goals for speech reading include develop an ability to recognize speech using auditory signals, interpret auditory experiences, use residual hearing to maximize their hearing, and desire best amplification, so for more raw material to work with. Auditory training continued. It is critical. It does not change hearing sensitivity, but increases sound utilization. Getting amplification is not equivalent to getting a glass eyes. So note that a person fitted with appropriate amplification, once they receive the amplification, they must be trained as how to use it for the auditory signal. And there's 4 design principles with this. There's auditory skill, stimuli activity, type difficulty, and level. So the 4 levels of auditory skill development include sound awareness, which is the most basic. It's detecting the presence of sound. Sound discrimination, are two sounds the same or are they different? Identification, able to label auditory stimuli. And then comprehension, which is the most difficult, is a higher auditory skill, and you're able to understand the message that is spoken and the meaning behind that message. So it goes from most basic to most difficult. So these are kind of the ways to vary difficulty. We'll get into more detail about them, but you can just check out, pause this, kind of look it over, and then we're going to go into more detail. So for stimulus units, there's analytic, so attention is focused more on segments of the signal, such as acoustic cues, voicing, syllables, and phonemes. And then there's synthetic, so recognition of the meaning of the utterance. So activity type can be informal, which is a training activity that occurs as part of the daily routine, often employed with infants and younger children, so incidental teaching. And then there's the more formal, where training activities are highly structured and may include drill. And then for difficulty level, you can kind of adjust the stimulus set, so it's closed or open stimulus, the unit, words versus complete sentences, and then stimulus similarity, so if they're dissimilar or similar, so like hippo and cat versus using cat and bat is more difficult. Context, so high or low, does the context of the message match the environment, or is it something completely related to where they're at? And then the task, so it's structured or spontaneous. And then the signal to noise ratio, which looks at good versus poor, such as things like the distance from the speaker and the talker, and then background noise going on in the room. And then Also, you need to assess what level the client is at. And then you need to begin developing objectives on the client's auditory skill level. If necessary, first target awareness of sound with play or toys, and then write objectives across all auditory skill levels while considering difficulty levels for each. For sound awareness, there is the gross discrimination of loudness or pitch or rate. And then, so when you are working on individual sounds, for vowels, you want to be thinking about formants. And then for consonants, you want to be thinking about place, manner, and voice. And then for the hierarchy of those consonants, there's awareness, discrimination, identification, and comprehension. And then we're going to look at the pros and cons of commercial auditory training programs. The pros are that it's flexible for the patient to complete when they have time. It doesn't require a trip to the clinic to meet with a professional. It's kind of on their own time. And then the patient can complete their training at their own pace. And it's often less expensive. There are cons, and that includes that the patient may and parents may not be accountable as they should be with their scheduled sessions or appointments they might have. And then they're not as tailored to specific needs of the client, so it's not as individualized. And often more analytic training is used, which can be difficult to generalize to their natural environment. And depending on the patient's level, the training may be drastically too difficult or too easy. So, for amplification, once a child has been properly fit with the appropriate amplification, we need to make sure it is providing him or her with appropriate access to sound. So you can do this in a variety of ways by looking at verification, which and then also validation. So the parent, that can be so the verification can be done with real ear measures such as hearing aids and BAHAs, and then the validation can be done by parent and child questionnaires, speech perception testing, and aided audiograms. So for validations, we typically use speech perception training, and it is one of the biggest ways to access the child's speech and success with amplification. And then there's a choice of assessment, which can be administering an assessment. They can be bias and multicultural considerations when you're using the speech perception testing. So just all of those play into how well the child will do with the speech perception training. So there are several laws that individuals can qualify for. So PL 94-142 it is born from the civil rights laws, and there's FAPE, which ensured protection that people ages 3 to 18 are covered, and then there's LRE, and then it reauthorized and is known as IDA, which includes children and individuals from the age of 3 to 21 years old. And there's PL 94-457, and it extended the previous law to early childhood, so birth to 3. And then Part C of IDA reauthorized in 2004, aligned with the No Child Left Behind. So the main principles of this, the IDEA law, is you determine that the children has the disability. There is a pre-referral process for that, and then there's an evaluation process, and then there's the IEPs, and then due process, which helps with the parents, and then they're also eligible to receive related services, and also the concept of the least restrictive environment. So for the individualized family service plan, it is for birth to 3 years old. It emphasizes the family involvement and looks at child's development, family concerns and priorities, medical in their house, service coordinator, plan for transitioning into preschool, language models, facilitative language techniques, and then parent support groups to share feelings, and then also daily living routines to teach communication. So all of that is incorporated in it. For an IEP, it has quite a few team members, so the child, especially if they're over 14, the parents and caregivers to advocate for the child, the school nurse, audiologist, and the speech language pathologist, DHH teacher, general educator, otolaryngologist or the ENT, and then psychologist, social worker or vocal rehabilitation individual, special educator, and administrator or LEA interpreter. So, for a child with hearing loss, the audiologist has some specific roles. They need to evaluate hearing and speech recognition. They need to select, fit, and help maintain appropriate listening devices. They can provide speech perception training and provide counseling, as well as consult with parents and other professionals on the team. So the speech language pathologist roles are to evaluate speech and language performance, provide speech and language therapy, consult with parents, teachers, and other professionals, and often bridge between the audiologist, teachers, and parents if they're in that school setting. And then provide speech reading training, sign language, and auditory training as appropriate or fitting for the child's and parents' wishes. And then also advise the audiologist on what test materials they're using and what they're working on. So, factors that influence parents' decisions on what the child is involved in depends on location, professional advice they receive, family variables such as their individual goals and what they want to achieve, and then the child's variables as well, and other professional experiences and expertise that they have encountered. So, for classroom signal to noise ratio, just be aware that a classroom is noisy. It's anywhere from 50 to 60 decibels, and a lot of the sound is bouncing off the walls, so it is important to keep that in mind. And then think about the normal conversational level that the child is having with all this background noise, and then for optimal auditory comprehension, the speech to noise ratio of +6 for adults. And then for a child, it's +15 to +20 decibels. So a child with moderate hearing loss perform 13% worse in speech recognition with good sound to noise ratio. So they perform 33% worse when the signal falls below -6. So speech characteristics for these individuals include segmental errors, such as errors in speech sounds, and suprasphagmatal errors, errors in speech prosody and their prelinguistics, intonation, such as pitch, stress, and tone, tempo for like rate, duration, rhythm, and pause, loudness, and then overall intelligibility may be decreased. And then for language characteristics, they might be off with their form, so they might overuse nouns or verbs. They might have rare use of adverbs, prepositions, and pronouns, and they may omit function words. For context, they might have a restricted vocabulary, and for use/pragmatics, they might lack initiation skills. Literacy characteristics for reading. Decoding might be difficult, reading comprehension, and their underlying language challenges with that syntax and semantics may affect their reading. And then there may be a mismatch of instruction. For writing, their underlying syntactic and semantic errors, review/editing skills might be compromised. And for phonological awareness, there's a hierarchy of skills. So there's syllable segmenting, syllable blending, rhyming, phoneme blending, phoneme segmenting, syllable and phoneme manipulation, and then ELLA and PAT are 2 assessments we can use to look at these phonological awareness skills. So for literacy deficits, there are 3 main reasons for literacy deficits in children who have a significant hearing loss. They have a restricted language system, which deficits both their vocabulary and syntactical structures. And then they do not develop an auditory bias for mapping sounds to print. And they typically have deficits in experience and wordly knowledge due to that less language input. So for assessing speech and language skills, you can do formal or informal measures. You can perform with the preferred mode of communication. You need to establish a rapport when you do this. And you can use test materials and procedures that are age appropriate and match the child's language ability. And then try not to use tests with norms for children with hearing loss or acknowledge violation of the norms. Roles of an SLP and hard of hearing teachers include the SLP's audiologists. The SLPs, audiologists, and teachers of the deaf and hard of hearing should work collaboratively all together, and they need to develop communication, and then early intervention is essential, and communication through a variety of modes, languages, and strategies. And then they should do some overlapping with their services as well as complementary services, and really consider the developmental milestones and academic expectations that the child should have. So for SLP involvement, there's the auditory training, speech production training, language intervention, phonological awareness instruction, focus on literacy, and classroom and home liaison. Okay, for auditory training, you're going to want to be focusing on the awareness, discrimination, identification, and comprehension. So there's the analytic level training for perception of speech or sound, and then minimal contrast pairs, and then you vary the amount of visual stimulation. For the synthetic level training, you want comprehension of speech, elicited repetition of complete sentences, and for communication repair strategies, repetitive prompting, and insert ambient noise. For language intervention, vocabulary is really key here. So content and concepts, and then categories as well. And then for morphological and syntactical markers, there's the verb test, and then plurals. And then for possessive figurative language, you can use that through humor and ambiguous language. So, for the focus on literacy, you connect phonological awareness, speech production, and language skills through the literacy activities, such as reading books, telling stories, writing stories, giving presentations, pairing print and speech, talking about letters, and using classroom content. So that is all I have for you guys. Just know that if you have any questions, you can reach out to me via email. It's on here. And then also I'll be available for Skype calls on this Sunday. So that'll be between 1:30 and 3 p.m. So email me if you're interested in this. But good luck studying!